Welcome to episode 201 of the Pharmacist Voice podcast. I'm the host, Kim Newlove. Today, I'm discussing pharmacogenomics with Dr. Dave Kisor from Manchester University College of Pharmacy, which is located in Fort Wayne, Indiana. If you're interested in pharmacogenomics, you will like this episode. And FYI, if you don't know a thing about pharmacogenomics, please be advised, we are using the abbreviation PGx for pharmacogenomics throughout this conversation. If you are new to the topic, I want to make sure you're on the same page with us right from the start of this episode. Enjoy. And if you are new to the Pharmacist Voice podcast, welcome. Again, my name is Kim Newlove, and I'm the host. I'm a pharmacist by training, but I'm not in clinical practice anymore. I made a career transition to voice actor and podcast host. I help my clients get their point across in the medical space. Among other things, I narrate audiobooks for women pharmacist authors. I provide medical narration to clients in the pharmaceutical, biotech, and continuing medical education industries, and I narrate content for explainer videos and e-learning projects. I was inspired by my nonverbal son, who has autism, to combine my background as a pharmacist with my speaking voice and launch my business, The Pharmacist Voice, in 2017. My son Craig helped me realize the power of having a voice and using it. My solo podcast episodes are about some aspect of being a pharmacist, a voice actor, a pharmacist podcaster, or my career transition from pharmacist to voice actor and podcast host. My interview shows feature a variety of people who use their voices to advocate for something, educate in some way, or entertain so that you are inspired to use your voice too. This is episode 201, and you can find the show notes on my website, thepharmacistvoice.com. Just click on the podcast tab and search for episode 201. Let me give you some background on Dr. Dave Kisor, then we'll dive right into our interview. Dave Kisor is professor and director of pharmacogenomics at Manchester University. He graduated from The Ohio State University College of Pharmacy with his PharmD in 1986. Then he completed a 2-year fellowship in therapeutic drug monitoring and pharmacokinetics at OSU. Prior to joining Manchester, Dave was professor of pharmaceutical sciences at Ohio Northern University after being a research scientist at Burroughs Wellcome Co. /GlaxoWellcome. He's been a clinical PGx consultant since 2012. He has over 80 peer-reviewed publications, including being the lead author on 2 pharmacogenomic textbooks. He is a past chair of the American Association of Colleges of Pharmacy, PGx SIG. That's Pharmacogenomics Special Interest Group. Dave was named a Fellow of the American College of Clinical Pharmacology in 2017. In 2021, he received an AACP Innovations in Pharmacogenomics Teaching Award. His current research is related to pharmacogenomics and opioid use disorder. He also serves as co-chair of the Pharmacogenomics Global Research Network Education Committee. Without further ado, here's my conversation with Dr. Dave Kisor. Hi, Dave. Welcome to the Pharmacist Voice podcast. How are you?
I'm doing fine. Thank you for inviting me to join you. I appreciate it.
My pleasure. A fellow Ohio pharmacist. It's always great to have an Ohio pharmacist on the podcast.
Yeah, I've been an Ohio pharmacist licensed since 1984. And so, a longtime pharmacist, just passionate for the profession.
Awesome. And I believe we both did our undergrad at the University of Toledo in Toledo, Ohio. Is that right?
Yeah, it sure is. I worked at a local community pharmacy in the Cleveland, Ohio area, and all of the interns were in school at Toledo. So I just went to Toledo and actually loved every minute of it.
Awesome. I had a good experience as well. Go Rockets.
Yeah, go Rockets, right.
And then you did your graduate degree, your PharmD degree at The Ohio State. Is that correct?
Yeah, right. So back then, right, the Bachelor of Science was the entry-level degree for the profession of pharmacy. And there was this, quote, new thing called clinical pharmacy with the PharmD degree being offered by a number of institutions. And so I decided to go down that path and ended up at Ohio State And it was beneficial for a number of reasons. First of all, it was an excellent additional education, but it's where I met my wife of now 37 years. So it was a great deal all the way around.
Awesome. Awesome. Well, I did my courtship a little bit differently. I met my husband in high school, and then I followed him to the University of Toledo, and things went from there. And we're celebrating 30 years together as a couple.
Well, congratulations.
Thank you. Thank you. It'll be 22 years married in June. Congratulations to you as well. That's great. We know how to stick with something, don't we? Pharmacy and our partners.
Yeah, it's worked great. I've got the best.
Awesome. That's great. Well, congratulations again. Now, I invited you to be on the podcast today to talk about pharmacogenomics. You are experienced, and I have actually heard you speak at the mid-year meeting of the Ohio Pharmacists Association on the topic of pharmacogenomics. You know your stuff, sir.
Yeah, it's interesting because for me, going to school from 1979 to 1984, the 5-year program at Toledo, that topic, that discipline was not discussed. It certainly was alluded to with some specific pieces of information for drugs that some patients were using at the time, but the term pharmacogenomics was nowhere to be found. I went down the path of pharmacokinetics, and we always understood that there were patient differences, certainly in physiology as patients got older, pathophysiologies that add to the altered physiology. And then we knew there was an underlying genetic component, but we didn't have the technology to get to it. So the kinetics really connected because I saw technology come along in the 1970s and 80s that allowed us to look at drug concentrations. And that was new at the time. And then we saw therapeutic drug monitoring services pop up at institutions. And then it got to be ubiquitous, and it was just part of pharmacy training. And I'm seeing the same thing happening now with pharmacogenomics. So I was fortunate because there was a very good connection between pharmacokinetics and pharmacogenomics. And I decided to go down that path in the late 1990s.
Very cool. I didn't even hear about pharmacogenomics until the Pharmacist letter came out with a CE, or a little blurb, I guess, a paragraph in their monthly CE. I want to guess that year was probably 2015 or something like that. Do you happen to remember that one?
I don't remember that one specifically, but I did some research to look at the origin of these terms. And pharmacogenetics used to be the preferred term. Now the preferred term is pharmacogenomics. It's a little bit broader. But pharmacogenetics was coined in the late 1950s. So that term has been around for a long time. And it's just evolved. And what made it evolve was the technology that came out of the Human Genome Project and post-Human Genome Project. That's what really allowed high throughput testing, which had a better turnaround time. It's been getting better ever since.
I became curious about pharmacogenomics or pharmacogenetics, however you want to say it, back in 2015 when I read that Pharmacist letter paragraph. But you, sir, how did you get interested in pharmacogenetics or pharmacogenomics?
Yeah, so in the late 1990s, I was at Ohio Northern University as an instructor there, a teacher, and I was responsible for pharmacogenomics across therapeutic areas. And there were a couple of drugs that were related to N-acetyltransferase. And we used to call the differences in metabolism based on that fast and slow metabolizers back then. And so I got curious about knowing fast and slow, but then I thought, well, that's all well and good from the ivory towers of academia, but we don't have that information clinically. And so I started to dig into it more, paid attention to the Human Genome Project. In the early 2000s, then at Ohio Northern, we instituted an elective in pharmacogenomics. And John Sprague, who was dean at that time, really helped promote that. And then I just ran with it. I did my own education on it. I wasn't formally trained in pharmacogenomics, but I felt that it was coming, and it is. So it's one of the few times I called something right, at least as far as things that were going to change in pharmacy practice. I can remember doing some presentations for different groups, from retail, what I like to call community pharmacy, not so much retail, but community pharmacy, to health institution programs, to introduce the topic. And I think really from the standpoint of where it evolved is layering it on to what pharmacists are already doing as far as non-dispensing services. So I think that's kind of what really drove me. I saw this as a real service opportunity for pharmacists.
Excellent. Way to pick a trend. Not everybody saw this coming. And even now, not a lot of pharmacists know about it. There's not necessarily formal education in every single pharmacy school. I mean, I don't know. I haven't looked at all of their programs, but I can't imagine that they have the extent of a program that you do at Manchester University there in Fort Wayne, Indiana.
Yeah, that's a great point. In 2005, there was an initial survey of pharmacy schools and what they included in their pharmacogenomics education in their curricula. It was not required back at that time. That survey was repeated in 2010. And then about 3 or 4 years ago, another set of schools were surveyed. And we see it growing. It is required in pharmacy education. In 2016, the American Council for Pharmacy Education made pharmacogenomics one of the requirements for curricula. Having said that, they didn't say the extent to which that needed to be taught, right? And so you find some schools that have introductory courses, some schools that have integrated it throughout therapeutic modules. Now, at Manchester, we really took this as an opportunity to be leaders in pharmacy education. We had the first master's program in pharmacogenomics that started in 2016. And then importantly, in 2018, we expanded that to an online effort to reach more healthcare providers. But to me, the biggest effort that Manchester has put forth is the dual degree program, where we have pharmacy students in their PharmD program that will also graduate at the same time with their master's of pharmacogenomics degree, Master of Science in Pharmacogenomics. And that to me is the real meld, the real fit. Because of our training in pharmacology, in therapeutics, pharmacokinetics is a subcategory of pharmacology, and of course pharmacodynamics in there with pharmacology, we are really the perfect fit for promoting pharmacogenomics. And I think that the therapeutic standpoint, to me, speaks to layering pharmacogenomics on top of medication therapy management. I think we all recognize that we are not getting reimbursed for our cognitive services to a great extent, right? That we should. And so one avenue is to layer on an MTM and bill through MTM. And maybe I'm getting too in the weeds here, but my point is that Manchester has thought through a lot of this. And so we've been really leading the way, I would say, since about 2016.
One of your students, Miriam Yassin, was on my podcast. I'm sorry I don't have the episode number in front of me, but Miriam was very impressive in that she was, like you said, getting the PharmD and the master's in pharmacogenomics at the same time. How many students have you graduated with the dual degrees? Do you happen to know?
I think we're approaching 30 to 40 now. When we look at our original program in 2016, which was on campus, and we typically have about 10 to 12 students. And it depends, of course, COVID impacted that. But then online, which is the largest cohort that we have, and we enroll students to start the program online in the fall and in the spring. And then the dual degree, I think we have, approaching 60 students at a time that are being trained in pharmacogenomics. And I'm not sure that's happening anywhere else at that magnitude, to that depth. Certainly, there are larger pharmacy programs that teach pharmacogenomics, but within the context of a master's program where we focus on implementation and on really getting through the guidelines and applying pharmacogenomics, I'm not sure that that's being done at the magnitude that we're doing it.
I think that you have to meet people where they're at. And if you've already got somebody who's going through a PharmD program and they're interested in the pharmacogenomics and you're offering that master's degree, I think that's a great time to get them some formal education. But I do also recognize that there are other ways for pharmacists to become educated about pharmacogenomics. I know that the pharmacist letter only had a paragraph, okay? So there are other resources out there. Some of them are Dan Krinsky and Sue Paul's PGx 101. And then we've got Jamie Wilkie with the Pharmacogenomics Confidence Counseling Academy. I always screw up the two words. It might be Counseling Confidence Academy. But anyways, there are some other options out there, or people can, like you, become self-educated. For pharmacists out there who are looking to become educated about pharmacogenomics and it wasn't part of their formal education, what do you recommend?
Yes, I think there's a number of different avenues. You mentioned Dan and Sue, excuse me, and others have programs. They are typically related to continuing education with CE that's available. I think a good place to start, just to get your feet wet, if a pharmacist is not familiar to any great degree with pharmacogenomics, is right now there's a free 2-hour continuing education program through Advanced CE. And that is looking at pharmacogenomics relative to commonly prescribed medications. So this was an effort by Manchester students, myself, and then a faculty member from another institution to relate the common medications in pharmacogenomics. Now, we did this back in 2012 also, and at that time, roughly 11% or so of the drugs in the top 200 had pharmacogenomic implications. Now it's over 25%. And
Wow.
we're gonna start to see that grow. So think about that. 1 in every 4 medications in the top 200 has a pharmacogenomic implication. And here we're talking about implications that are backed by evidence-based guidelines. So there's that 2-hour CE, I think, which is a good kind of dipping your toes in the water to see kind of what it's all about. Then there certainly are certificate training programs. We offered the first one through the American Pharmacists Association back in 2015. That went online and is still active through a private entity that's providing that, I think, 8 hours of CE. But I would encourage people to search the internet and put in the search terms pharmacogenomics certificate program, and a number will pop up. They're offered through academic institutions. They're offered through societies and associations. I think that's a good place to start. And the whole point with that education is to expand the pharmacist's knowledge base and their clinical skills. If a pharmacist is interested in pursuing a deeper education along the lines of implementation, then they can look at programs like that Manchester offers right now. Having said that, we were the first again in 2016, and there are others now also, maybe having broader programs called precision medicine, which is another term that we hear. But pharmacogenomics is the focus at Manchester. So I hope that answered your question.
It does. It gives people that are listening to this a really good idea of search terms and different institutions that might have more valid training than others. I know that sometimes the person putting out the information is just as important as the information itself. You don't want to just go to somebody who doesn't have any formal experience with pharmacogenomics. You want to go to somebody who does this as their subject matter expertise.
Right. And I think that we've got some great leaders in Ohio. Again, you mentioned a number of folks earlier that can be consulted with about education. And certainly folks on your podcast can feel free to reach out to me also. I've got an email that I use outside of Manchester, so I don't get inundated with Manchester emails and get things lost. I have a number of students that I focus on, and sometimes I miss emails and get so many of them. But Dave at PGxEd.com is another way to reach me. And I can help with pointing people to educational programs also. So that I'd be more than willing to do that. I'm passionate about this, and the more people that know about pharmacogenomics, the better off we are. And especially the public, right? We need to reach out to the public also.
Yes, and we need to get educated so that the public knows that we know about this. I think it's going to take a little while for the vast majority of pharmacists to catch up with the information that's out there. Not all of us graduated with that information in our programs. Like you were saying, they are starting to do starting in 2016. But there is a way that we can catch up and dip our toes in the water. But more importantly, we need to get educated about this because, like you said, there are pharmacogenomic implications among the top, 25% of the 25% of the top 200 drugs in America have pharmacogenomic implications. So let's talk a little bit about that. How are pharmacists being approached about these questions related to pharmacogenomics? Are patients coming up to them, prescribers? Are they, taking it upon themselves to look up these things when the prescriptions come through? How do pharmacists even know what they're supposed to know?
Yeah, that's a very good question. And I would think I would guess that there are pockets where there are patients, clinicians that are approaching pharmacists. It isn't ubiquitous by any means right now, but it's going to get there. And especially because there are some direct consumer pharmacogenomics tests that are done. And we can talk about those. But I think that how do pharmacists know about pharmacogenomics and how can they be prepared for that patient who could walk in the community pharmacy because they're the most accessible healthcare provider, the pharmacist in that setting, and be asked about it. Now, to be honest with you, for my own, I won't say enjoyment, but for my own interest and passion, whenever I go to some town somewhere and there's a pharmacy around, I will go into that pharmacy and I will literally go back to the counter and I will ask to talk to the pharmacist and ask if they do pharmacogenetic or pharmacogenomic testing. It's an informal survey in my mind, but I'm reminded time and time again that we've not done the best job at getting this information out to all the pharmacists that need it. Because rarely does a pharmacist respond, "Oh, yes, I can tell you all about that." That's only happened a handful of times. Most often, they refer me to a local university for information, which is a perfect response. It's a perfect referral. It's just that folks have not been trained in this. And so I really love that insight from the pharmacist who says, "Oh, you know what? Talk to so-and-so at the University of wherever," right? And what happens, at least in Ohio, I taught for so many years at my former institution in Ada, that I run into a lot of pharmacists that I trained in part, and it's really fun, right? And some of them will even, cut me off at the pass, if you will, and say, "Don't ask me about pharmacogenomics." But they know about it, right? They mention the term and everything, so they're just joking, really. But no, I think that the community pharmacists, in particular, may find themselves in the position of having patients who bring in direct consumer information that they're going to be asked to interpret and say, "What does this mean?" So I think that's going to happen more and more.
Ooh, I've got to ask, what is this information that patients are bringing to their pharmacist? Tell me about this.
Okay. Well, I'll first say with a caveat that I'm not promoting any given organization or company, but I'm relatively sure that many people have heard of 23andMe. They've got a huge marketing campaign, both print, online, and in the the TV arenas, if you will. And part of their testing includes pharmacogenomics. And the Food and Drug Administration, the U.S. Food and Drug Administration, has approved actually 23andMe to report on 3 different genes at this point in time, and they include cytochrome P452C19, so CYP2C19, and also SLCO1B1, which is another gene, and then also DPYD, a third gene. And relative to the CYP2C19, the FDA has approved the use of 23andMe information relative to 2 marketed medications, clopidogrel and citalopram. So when we think about the process of direct-to-consumer pharmacogenomic testing or genetic testing in general, an individual may see a print ad or a TV ad or radio, what have you, and order a testing kit. And they get that kit sent to them. They open the kit. There's a collection tube for saliva. You go ahead and fill that up to the required amount, put the top back on, put it back into the box and send it back to 23andMe. And then you're notified via email when your results are available. And those results, again, can include information about certain, what we call phenotypes, how people express their genetics. And that could be related to drug response, such as clopidogrel, antiplatelet, or citalopram. And so individuals may get that information back, but notice nowhere in that process is there a healthcare provider. There's no pharmacist in that process to interpret information. Certainly 23andMe has worked with the FDA to get information provided online that the consumer can read. But in the context of the consumer's medications, what they're taking, what's their total medication list, that is not something that 23andMe collects. And therefore, they may go to the pharmacist and say, listen, I'm taking these medications. What does this mean? How does this impact me? And so that's the potential context.
Thank you for sharing that. Now, as the pharmacist on the receiving end, who, like me, went to school 20-some years ago, only got her bachelor's. I did like you did. I got the bachelor's first, but I never got the PharmD. And say I haven't had any formal training in pharmacogenomics, somebody comes in with this report about their 2C19 and they're taking clopidogrel. What am I supposed to do with that? How am I supposed to know what to do with that?
Yeah, so that's where resources need to be available to pharmacists, and pharmacists need to know about those resources. And again, in my general laissez-faire survey of pharmacists, we don't have that information readily available. And so it's going to take the individual to do some searching. Now, fortunately enough, there are a couple of very good resources to go to immediately. One would be the Clinical Pharmacogenetics Implementation Consortium. That is cpicpgx.org. And that organization is probably now roughly around 600 individuals from around the world who work to vet the literature and, where appropriate, put together clinical guidelines and disseminate those guidelines. And those guidelines are freely available online at www.cpicpgx.org. And so that's one place to look. There's a clopidogrel guideline there, right? And that information can be looked at in reference to that specific question you mentioned. There's guidelines for citalopram and other medications used for behavioral health. The other SSRIs, or the TCAs are there also. I think now there's 26 total guidelines that cover more than 110 medications. So that's one resource. The other one is PharmGKB, the Pharmacogenomics Knowledge Base. And that includes clinical guidelines, not just from CPIC, but also from the Dutch Pharmacogenomics Working Group. And by the way, let me talk about the Dutch group very quickly. Just last week, this would have been the 3rd or so of February 2023, the Dutch group published the results of a very broad study across 9 countries in Europe, where they used preemptive pharmacogenomic testing. What that means is before patients were put on medications, they got their genetic testing done relative to drug response. And they found that using pharmacogenomics decreased adverse drug reactions 30% compared to a comparative group that did not get pharmacogenomic testing. So that's very, very important, not only from saving the patients the issues related to the adverse drug reactions, but imagine the cost savings also.
That's good looking out. I'd rather prevent a problem than have to treat it.
Yes, that's a real kind of binary approach to pharmacogenomics right now. There's what we call reactive or reactionary pharmacogenomics, where somebody is either not responding to a medication or they have an adverse drug reaction, and testing is then performed. And it may explain it or it may not. The other is the preemptive, which I mentioned, which is what the Dutch have done. And that really, to me, is the, quote, holy grail, if you will, to prevent drug inefficacies and adverse drug reactions. The problem is that payers are not willing to invest that money up front. When you think about insurers, somebody may stay on the insurance plan for on average 2.5 to 3 years. And so payers can envision broad screening, which is very costly, but then people leaving their insurance and going to other insurance plans and reaping the benefits of the testing with other insurers. And so they don't see that upfront, right at the start return on investment. So it's going to take a while for preemptive testing to take hold. I do perceive, though, that someday, decades down the road, pharmacogenomics testing will, or at least preemptive testing, will occur at the time that a newborn is ready to be tested, and that will be housed in a secure database that can be queried as the individual gets older and may experience some pathophysiologies where they need medications. It just makes sense.
It does make sense. And I like that. You're the first person I've ever heard say that, but that just makes sense to start testing newborns so that that information is available for their lifetime.
Yeah, I'm certainly not the only one that has said that. We've been saying this really for a long, long time. In the context of pharmacogenomic testing right now, the common approach is what we call a panel. For instance, the Dutch group used 12 genes. We're not looking at the whole genome. We're not getting information by and large on risk for disease states. There are some secondary findings that we have with pharmacogenomic testing, but it's really very narrow related to drug-gene interactions that we have information on. So it's not a broad survey of somebody's genetics. Now, that doesn't mean that you can't find out information about somebody beyond pharmacogenomics, but what it does mean is that we're not going to be able to interface with patients relative to disease risk, if you will. And that's certainly not the pharmacist's role, really, but they do know how to, they do need to know how to counsel patients on secondary findings, maybe referring them to, where appropriate, a genetic counselor or a medical geneticist.
Let's say a patient comes in with their piece of paper with their pharmacogenomic profile on it and takes it to the pharmacist and says, hey, I want you to look at my meds that I'm on versus this information here. What are the chances of a pharmacist being able to access those databases that you talked about and being able to understand right there on the spot how to respond to that patient?
So I think that the Clinical Pharmacogenetics Implementation Consortium guidelines are very straightforward. There are typically two major components to the guideline. One is what we call translation from the genetic information to the phenotype. So the genetic information may be their basic gene results, right? The testing results, right? And the phenotype would be how they express those gene results, okay? So that's one component. The other component is the connection between the phenotype and clear therapeutic recommendations. So with a little bit of time, and I would say minutes here, on a broad sense, a pharmacist could look at those guidelines and potentially help an individual. I think more importantly is to look at those as learning opportunities to take your time and get back to those patients. I want to say that from the reactionary standpoint, when patients aren't responding to medications, the prescribers, whether it's a physician assistant, nurse practitioner, who have you, and the pharmacist want those patients to get to that medicine that's going to help them. And the earlier in therapy, the better. So I think it's all an iterative process. It goes back to what we're teaching pharmacy students right now, which we've done forever, Kim. We've always had the process of gathering and collecting information, assessing that information, right? And then putting a plan together, implementing that plan, then following up, and then tweaking that plan and modifying that plan, collecting the new information, and just doing that over and over again, something that we now call the pharmacist patient care process. And pharmacogenomics fits right into that process. And so it's learn and relearn. So that the question you ask, immediately be able to do something, I think there's a first look that can be done, but I think it needs to be done in the context of learning and then reconnecting with that patient. Now, in some cases, it's going to be very important to get a hold of a prescriber and say, this individual is at risk for this, that, or what other information is available. And it puts you in the front line. It puts you squarely in a probably a little bit of a stressful situation because we have not been broadly trained in this, but it's going to allow you to get some experience. Yeah.
This is a cautionary tale, and I want my listeners to know that if you are in community practice and it is possible for someone to come up to you with a report, do that recommended CE that Dave talked about. 2 hours, and you said it was on which platform again? Advanced CE, is that right?
I think it's advanced CE. It may be through Drug Topics or Pharmacy Times.
Let's put a link in the show notes.
Yeah, and I think that's a great point. That is a quick way to at least have some familiarity with it. And by the way, all the references to medications and pharmacogenomics in that continuing education piece are those that are backed up by the clinical guidelines. So they're all referenced in that piece. So it can be a very good starting point.
Yes, we love our good sources, don't we?
Yes, absolutely.
Absolutely. Yeah. And I'm not, bringing up this example to freak anybody out who's, my age and hasn't had the training yet. But hey, you still have an opportunity. You can start today, get that 2 hours of CE, start thinking up some scenarios that your patients might put before you and go through a couple of practice runs, right? I mean, that's what homework's for, right, Dave?
Yes, absolutely. And I also think it's an avenue for a pharmacy, whether it's an independent, a small chain, what have you, to connect with the public. I mean, I can envision pharmacists providing education for their community members, say at a local library, and say, listen, if you've done 23andMe and you've got this information and you want us to look at it, it's a way to connect with the community and maybe to initiate a pharmacogenomics service, which can then be expanded to connecting with a laboratory and local clinicians, and really educating the public and the clinicians on how to apply the guidelines and benefiting patients. That's really the bottom line.
Yes, benefiting patients is important, but also my brain is continuing to think about what else can we do with this. We could also monetize it. I think as we opened up this conversation, you talked about how PGx is now becoming something like MTM where you can monetize it. What are your thoughts on doing that as a community practice?
Yeah, so a couple of things on that. First off, when we look at the payer landscape, payers have been reluctant to pay for pharmacogenetic testing until there's been a broader and deeper evidence base, and that's happened. Now, over the last 2 years, in 2020 and 2021, Medicare administrative contractors, two in particular, MolDX and Navitas, have put forth positive local coverage determinations to pay for testing. So that is a positive. Let me say, though, that's to pay to get the testing done. That's not paying pharmacists or the other healthcare providers for their cognitive function of interpreting that data, right? And so that's where layering that onto MTM can be a way to at least bill through MTM to get that done. However, the cost of testing has come way down. And I would say that for individuals, if they plan to pay out of pocket, you may be looking at $250 to $450. Now, certainly there are socioeconomic pockets or groups of individuals that cannot afford that, and I understand that. But there are ways to work around that and work with insurers, and private insurers are starting to follow, especially in the behavioral health area. I might also add that the whole idea of the payers has to come in the context of this is typically a one-time test. Your DNA doesn't change, and so it's through the end of life information that can be used. Now, there are some cases where we identify a new gene or a gene variant that hasn't been tested prior that may need to be tested, but that's few and far between, I think, at this point. So again, that test lasts the rest of an individual's life. When you think about retesting renal function or liver function or cardiovascular function or what have you, the cost of pharmacogenetic testing in the end is much less expensive than these other tests. That's because it's a one-time test. Yeah.
I have very little experience with pharmacogenomics, but I do see the value in it. I know you're talking about insurers saying, hey, I don't know if there's enough value. I don't know if we're going to be preventing enough high expensive payments for things in the future. I get it. I get what they're trying to do. But maybe somebody says, as an individual, I value this information and I know that it will last me my lifetime. Therefore, I will pay for it out of pocket. You already talked about how it's just hundreds of dollars. And I know for some people that may be prohibitive. I get it. But for me, I would gladly pay $250, $450 to get that information that I could use for my lifetime. But I've got to ask you, I've run into a problem with my primary care provider, who is a certified nurse practitioner. She says, no, you don't need to get this done. I won't sign off on it. What do you do when your primary care provider won't let you pay your $250 or whatever out of pocket to get the information?
Yeah, so I think that comes from a standpoint of not being educated on pharmacogenomics. By and large, when primary care practitioners do not engage in pharmacogenomics, it's just like the large majority of them, they've not been trained and they're uncomfortable with it, and they also view it as a potential liability. Now, let's turn this around for a minute because the liability may lay in not testing an individual. If you're going to use a commonly prescribed medication that has a pharmacogenomic implication and you don't test, and that individual experiences inefficacy that leads to some dire consequence or an adverse drug reaction, then is there liability in that context? I think a good way to do it, at least from those of us that are pharmacists, and we've heard about pharmacogenomics, is introduce the primary care person to the guidelines. Say, listen, this is why I'm asking for this. I'm familiar with this. Now, of course, the general public's not going to do that necessarily, right? But let me tell you about a study that was published in January of 2022. This is from a health plan in northern Kentucky, and this was over 32 months. And they included pharmacogenomic testing on top of essentially MTM, or comprehensive medication management. It saved that health plan $37.4 million, roughly $220 per member per month.
Oh my gosh, that's amazing.
Yeah, that's the author. The primary author was Jarvis et al., and it was published last January, a year ago, a little bit more than a year ago. And it was one of a number now of papers that are coming out that speak to cost effectiveness and cost savings. And what happened was it decreased primary care visits, decreased emergency department visits, and hospital days. So that decreased the healthcare resource utilization also, and resulted in a large cost savings for the plan. So I would speak to individuals about cost savings for themselves, right?
As a pharmacist, I know this is a very specific case where I am a pharmacist, but I don't know about PGx, but I know that I could get this test that I could use the results of for my lifetime. I can't necessarily educate my primary care provider about it because I don't know enough myself. And I bet my situation is not unique, because I would say the greatest majority of pharmacists practicing today do not know about pharmacogenomics, but we want the benefits of it. So for somebody like me who's got this very specific problem, what would you recommend I do to educate my primary care provider, even though I don't honestly know what I'm talking about?
Yeah, I would say that, I'm engaging in learning about pharmacogenomics. I've seen the pharmacogenomics knowledge base. I've seen the clinical guidelines, and that is where we have to work from. It's not going to work if you don't have evidence-based guidelines to discuss with your clinician. And I think that's a perfect avenue to say, listen, here's why I'm considering this. Here's the guideline itself, or here's the link to the guideline. They're publicly available for free. There's even the published literature is free through clinical pharmacology and therapeutics, and that is it's gonna mean they're gonna have to do a little bit of homework, and I would expect that of my primary care doc, recognizing that it's not going to benefit only you, but other patients that individual has that they may consider then pharmacogenomic testing. I think we need to kind of poke and prod if you will, any way we can at this point in time. I think people in medicine are overwhelmed with the amount of information they have to deal with. And if an individual has, on average, maybe 7 to 11 minutes with a patient in the acute care setting or in their office visit, they're limited, right? And so however we can facilitate that, we need to do it.
I like that challenge. I will have to brush up on those guidelines and see if I can find the red thread that will appeal to her as a provider. Because like you were saying, there is value for her other patients. There's value in not being liable for not knowing. And I think maybe if I focus on what she's missing out on, maybe that will motivate her. I know I got to figure out the solution myself, but you've given me some great information to use. And thank you.
I can also offer a real quick analogy, at least
Sure.
from an acute care setting. Back in the days when pharmacokinetics was coming on board and we had therapeutic drug monitoring services, people weren't familiar with testing renal function or the aminoglycoside antibiotic concentrations. And clinicians were sued because they did not measure antibiotic concentrations. And people had renal dysfunction due to the aminoglycosides, mainly gentamicin, tobramycin, that could have been prevented. And that's not a scare tactic. It's the truth. It's what happened. So why would we want to re-engage in that same, approach, right? So I think we may not be doing a lot of preemptive testing, but we can be doing a lot of preemptive education.
Well said. I like that comparison because it might help me relate to her.
Yeah, absolutely.
She might recognize that. Yeah. Well, this has been a great discussion. Let's move on to some of the other topics that I have on my list. I love a good list. Sure. I know that we already talked about direct-to-consumer testing, how you got into pharmacogenomics, resources for pharmacists, that's CE. But I just wanted to ask you, I guess, as we're starting to close this up, what's next for you and what's next for pharmacogenomics? 2 questions there.
So I'll go with what's next for pharmacogenomics first. And I see an increase engagement in pharmacogenomics on a number of different fronts. First of all, again, Manchester was the first to have a master's program, was the first to do online, was the first to do the dual degree. And we actually have had students from other pharmacy programs engage in our master's program while they're in pharmacy school. And what's next there is, well, we see other institutions that have started master's programs of pharmacogenomics. There are now 5 or 6 other programs. So that speaks to a broader desire and demand for pharmacogenomics knowledge. That's one thing. From the payers, as I mentioned earlier, from Centers for Medicare and Medicaid Services, we're seeing increased payment. We're seeing that from private insurers also. The large insurers like United Healthcare are expanding their payment again, especially in behavioral health. So we're seeing, this happening is what's next. And as we see these publications, like those that come from the Dutch group that showed a 30% decrease in adverse drug reactions, there's going to be more interest. And by the way, that paper was published in Lancet. It wasn't published in a pharmacogenomics journal. It was published in a major medical journal. We're going to see more uptake because of that. Also, because of public education through direct consumer testing, also we're going to see. So there's a number of fronts where pharmacogenomics is going. I do know that in the state of Ohio, there's going to be an education program coming probably within the next 12 to 18 months, which I cannot expand on at this point in time, but I will say it's going to be funded and it will be available to healthcare providers. It will really be born out of some work that the state is doing on opioid use disorder and pharmacogenomics. So I think that's what's next. In the state of Ohio, we've got some great experts you mentioned earlier. I've certainly worked with Dan and Sue, and we all have approaches to education. You can reach out to us. So that's what's next in pharmacogenomics. I think it's going to hit that tipping point, and it will be eventually a standard of care like we do with drug-drug gene interactions or drug-drug interactions. For myself, I've been fortunate enough to find the pharmacy profession, first off, just as a kid who started folding papers at a drugstore and sweeping floors and And it was intriguing to me that these pharmacists were doing what they were doing. And then finding this whole thing called pharmacokinetics, because I was kind of into math and you had to do some math with that, right? And then pharmacogenomics in the late 1990s, connecting with pharmacokinetics. I'm passionate about it. I bring it up all the time, whether it's in a setting of other healthcare providers or other groups that I'm with. I've been consulting clinically since like 2010s, helping clinicians interpret the information. But for me, I'm going to be retiring from full-time work in May of 23 after 35 or whatever plus years of working, and I'm going to enjoy my family, my amazing wife, my children, my two amazing grandsons, and believe me, if I'm going to watch out for them, it's going to be through what I know is pharmacogenomics, and make sure that if they're going to get a medication, they're going to know how they may respond to that medication. And I've got a really good, solid evidence base to prove that for them. So I'm going to let my family benefit from it also.
Good for you. Congratulations on the upcoming retirement, and God bless you for looking out for your family. That's good. Not everybody's that lucky. Good for you.
I've been blessed, and I'll say also with my retirement, Manchester is really stepping up and making sure that all those wonderful people that work with each other at Manchester are going to keep the program strong going forward.
Well, that's good to hear. Then the next generation can rise up as well. I know that in the past, I'm glad that you brought up your consulting work, but I know that in the past you have authored some textbooks on pharmacogenomics. Is that right? Would you like to talk about that too?
Sure. Yeah. So the first one we authored was in 2013. And that book is now, I think it's out of print now. We moved to a relationship with the American Pharmacists Association and published a book called Pharmacogenomics, Foundations, Competencies in the Pharmacist Patient Care Process. The first edition came out, I think, just 2 to 3 years ago. And then a new edition came out just late last year. Now, the reason there's a new edition is pharmacogenomics is changing so rapidly. We get new information all the time. And so we want to make sure that we're on top of the drug-gene interactions that are of import, especially with the more commonly prescribed medications. And so, there's 3 textbooks out there. The most recent one, if anybody's interested, is the second edition of the Foundations, Competencies in the Pharmacist Patient Care Process. I would recommend that book because it's up to date, and APHA has taken the approach that we're going to be able to update the clinical information. I would encourage people certainly to get the online access to it because that's where it's going to be updated. If you buy the hard copy, it's kind of hard to update that. And I might add, I don't get any royalties for it. I don't want to be seen as trying to sell something I get money for. I do not. I'm just passionate about it. I felt it was needed. And we've got a group of wonderful experts that have helped write that book. A number of them at colleges of pharmacy, but also practitioners.
Congratulations on publishing those. Now, in your retirement, will you be consulting or publishing any educational materials?
Yeah, my wife worries that I'll be doing more work in pharmacogenomics after I retire than in my work with Manchester. And I am going to absolutely stay connected to it. I'm too passionate about it to let it go completely. I'll continue to work with colleagues and just continue to be blessed with their collegiality. It's just a great group to work with. I also just thought of something else. Kim, can I interject? I'm sorry. I should have brought this up before when you mentioned about where's pharmacogenomics going. Well, let me tell you where it's going also in employment and jobs. The University of California, San Francisco just announced that they are going to start a pharmacogenomics program. Now, I'm not talking about the academic side of things. I'm talking about for their health system. The Veterans Administration system, the largest healthcare system in the country, is hiring 120 pharmacists to educate and disseminate pharmacogenomics. So that is a huge indication that pharmacogenomics is or has arrived. So I forgot to mention those earlier, and I know that I have a number of recent graduates. We have a number of recent graduates from Manchester that are certainly interested in hearing these opportunities. So there's opportunities that are coming from the job market also.
I have to ask because there's going to be at least one listener thinking this. How does somebody find out about one of those 120 pharmacist positions in pharmacogenomics at the VA?
Yeah, I think it's U.S. Jobs. Go to that site, and it's the government website for jobs. I received an email, it was either earlier this week or late last week, I can't remember, that was a screenshot of one of the first postings at the VA through that website, and talked about what this pharmacist would do, including pharmacogenomics in there. So think about that. Pharmacogenomics actually in the job descriptions for pharmacists through the VA system. And this is going to be happening all over the place. I think that if you take the time and you're at a point where you want to do something new, and take the time and get some training, again, some of the certificate training programs, maybe formal education, you can open up doors now and get into leadership roles that you may have not even imagined earlier. So yeah, I know we're kind of jumping all over the place here, but yeah, things come to mind, and that's an important one, is the job market opening up.
That's a fantastic comment, because there are a lot of pharmacists out there looking to do something else. And there may even be several pharmacy students who recently are either in the program getting their PharmD master's combo, or have recently graduated, and they're just looking for that first job that's in their actual field of study, instead of just, filling the gaps until they find that first job that's really the best fit. I think a lot of ears have probably perked up during this conversation, and that's great. Save the best for last. That's great.
Yeah, that's good to hear. I know that certainly people can reach out to me. They can reach out to me at Manchester, dfkaiser@manchester.edu, or dave@pgxed.com. Either way, I'm passionate about it, and I will help somebody along the path however I can.
Awesome. Now, as we start to wrap this up, I have to ask, now that I know you're retiring soon, other than raising grandkids, consulting, and maybe working on writing educational materials for PGx, what does the future have in store for retirement for you?
Well, I think that as I've gotten older, and this may be the case for many, you start to appreciate things around you more so. Certainly, we plan to do a lot of hiking, a lot of nature, but whatever my grandchildren are doing, I want to be there. I want to be there to support them, and just love them and let them know that Papa D is there for them.
Awesome. I didn't know if you were going to say, you wanted to see every baseball stadium in the U.S. or, everybody's got their thing. My uncle Al Titkemeyer, who lives in Florida now, he wanted to see every single baseball stadium in the U.S. during retirement. And I think he's just about there finally. You never know what people are going to do. I didn't know he was going to do that. But you don't know until you ask.
Yeah, but I will say, too, one of the things that I will do is all of us who are pharmacists were trained by somebody. And I would guess that for a lot of us, there were certain individuals that were very, very influential in decisions that we made relative to our careers. And I'm going to be keeping an eye on the students that I've taught and checking up on them, if you will, whether it's through looking at papers that maybe some of those that went into academia have published, or sneaking into pharmacies and just saying, hey, who's back there? I love doing that. And boy, when I run into a pharmacist, it's amazing. I actually went and got a vaccination in another part of Cleveland, Ohio. And when I walked into the pharmacy, here was a former student of mine, just jaw dropped, say, "What are you doing here?" And I saw, I'm here to get my vaccination, for the pandemic. And it was just great to see that individual. I appreciate pharmacists to the nth degree, and really enjoy seeing my former students. So that's what I'm going to be doing, Kim. Thanks for asking. I appreciate that.
Oh, you're welcome. Sounds like a plan. I wish you luck on that. And I look forward to keeping in touch with you to see how retirement goes and see what you're up to. Yeah.
Well, thank you so much. And if you happen to notice anything in the news that comes out about pharmacogenomics and you have any questions, feel free to reach out.
Sounds good. Dave, thanks again for being here on the Pharmacist Voice podcast to share how you use your voice as a pharmacist. Take care.
Thanks, Kim.
Thank you again, Dr. Dave Kisor, for being my guest. I would like to close now with just a few comments. First of all, Dr. Dave Kisor has been passionate about pharmacogenomics for more than 2 decades. Wow, that's amazing. Sometimes I get curious about something and then I lose interest after one article. Not so for Dr. Dave Kisor. I hope you, as a listener, feel inspired by his passion for pharmacogenomics and how he uses his voice as a PGx educator, consultant, and author. He learned about PGx and he never lost interest. Second, I enjoyed hearing about what's next for PGx. It sounds like there's a lot of opportunities. Clinically, however, the greatest impact that I see is that we can improve drug selection and decrease adverse drug reactions. Third, if you are new to pharmacogenomics or PGx, I challenge you to take that 2-hour CE that Dr. Kisor recommended. Then, get familiar with the CPIC and PharmGKB websites. There's a link to all 3 of those in the show notes. If you need to start somewhere and you don't know where to start, well, now you have the first 3 steps. Why should you accept this Kim Newlove PGx challenge? Because when a patient comes up to you with their 23andMe results someday, or if Dr. Kisor stops by your pharmacy unannounced, you'll be more prepared. Get started today. You can do this. Fourth and finally, congratulations again to Dr. Dave Kisor for a long and successful career. You have earned your upcoming retirement. Congratulations. May you spend all the time you want outdoors and with family or reconnecting with past students to your heart's delight. It sounds like you have some great plans. Congrats. Now, let's wrap this up. Thank you for listening to episode 201 of the Pharmacist Voice podcast. Please visit thepharmacistvoice.com to read the show notes. In the show notes today, you will find Dr. Dave Kisor's bio and email, a link to Manchester University College of Pharmacy, so you can check out their PGx master's degree program. You'll find a link to that 2-hour CE on pharmacogenomics that Dr. Dave Kisor mentioned, the CPIC website, the PharmGKB website, my social media links, and more. Great show notes today, lots of links. Check those out, thepharmacistvoice.com. Now, if you know someone who is curious about pharmacogenomics and would like this episode, please share it with them. And if you like this podcast, please subscribe to or follow the Pharmacist Voice podcast on your favorite podcast player and YouTube to get each new episode right when it comes out. I'll be back next Friday, March 3rd with a new episode. It is a solo episode. It's one of my drug name pronunciation episodes. I love those. Thanks again for listening today. I'll talk to you next week.